everybody, it's Dr. Glockenflecken.
And Lady Glockenflecken.
Guess what? We are bringing our live show, Wife and Death, to Lebanon, New Hampshire, September 15th at 7:30 p.m.
That's right. Back to the Upper Valley at the Lebanon Opera House.
So I went to med school at Dartmouth.
Yep, I went to grad school there.
And we wanted to come back and put on a show for the community. We cannot wait. It's going to be a blast. You can find tickets at our website, glockenflecken.com/speaking, or go to LebanonOperaHouse.org. We'll see you in September. Hi. Welcome, everybody, to Knock Knock Eye with me, your host, Dr. Glockenflecken, your one-stop shop for all things eyeball related. You know what's been on my mind lately? The fact that I am on call July 4th this year. I try to only do this as little as possible. I can't remember the last time I was on call over 4th of July. But it's feast or famine in ophthalmology with, we never want to feast on like eye injuries on the 4th of July, but it's just, and in terms of like how busy it might be, because I've had a 4th of July call where I didn't get anything, nothing. And then I've had a 4th of July call where everybody in the surrounding neighboring towns decided they're all going to look into a fireworks shooter that's not operating at the same time, and it blew up in their face. I've had both extremes, and I have no idea what I'm going to get this year. It's like the way our practice call works is we share it with it's a large group that we share it with, and so I'm only on call on 4th of July like maybe once every like 7 or 8, 9 years. So this might be it before I retire. I don't know when I'm going to retire. No, I'm going to certainly be in my 50s, maybe even my 60s. Actually, I might not ever retire. I don't know. I don't know. When do people start thinking about retirement? I feel like I'm too early to even think about it. But anyway, I will be giving a very detailed update about my call afterwards. So in a couple of weeks, stay tuned for that. But I'm just kind of nervous about it. You know, whenever I transitioned, like it came from residency where I was on call all the time, level 1 trauma center, Iowa. You just get in the habit of like just being on call. It's like not a big deal, even though it still sucks. It's just like, you know what it's going to be. You're doing it every week. A couple nights a week in residency, and you're just used to it. And then I got into private practice, and like the first few years where I only have like 4 weeks total per year. It's magic. It's like, this is unbelievable. This is so easy. It's nothing. I like a baby could take this call. It's so simple. I'm just taking triage phone calls, telling people to come in on Monday, and occasionally going in to see a patient. But like compared to residency, it's nothing. And you lose that. The longer you have like easy call, the more you're likely to like lose perspective. That's what it is. It's a loss of perspective, because now I'm 10 years into my career out of training, and now I get nervous again about call, even though it's private practice call. What do I have to complain about? But it's like, it's so infrequent now. And I know people are going to be like, stop talking about this. You're making me angry, Glockenflecken, because I'm on call all the time and it's crazy busy. I'm a neurosurgeon or whatever you are. I get it. I have lost perspective, but just, this is my podcast. I'm able to talk about these things. And I'll tell you, I don't like it. I don't like being on call. I get a little bit nervous now because I don't want to have to go in and see patients on the weekend and after hours. I will if I need to, but no one wants to do that. So anyway, my point is I've lost perspective. 2018 me would be just horrified with how I'm feeling now about call, because 2018 me was welcoming it. Oh yeah, I'll do this. 3 weeks out of the year, please. A private practice call? not even covering a trauma center, a level 2 trauma center at best, not seeing any open globes or canalicular lacerations or even things like, I guess I do see angle closure glaucoma from time to time. But anyway, it's just, I've lost perspective. So I will let you know how it goes July 4th. All right. So this is what we're going to do today. We're going to talk World Cup. And not about, X's and O's with regard to soccer and how in like the all about sports. No, we're talking sports injuries. All right. I'm gonna go over all the eye-related World Cup injuries that I could think of. I brainstormed a few. I've got a handful for you. All right. So World Cup injuries, soccer injuries, reasons why you might want an ophthalmologist on the field ready to go. And I'll tell you right now, I bet I've never heard of a World Cup, a soccer, a football, a European football, or non-American football related ophthalmologist ready to go on the field. On this podcast, I've told you every professional sport needs an ophthalmologist around. We might not be very busy, but when you need us, you need us. All right. When you need us to help find a contact lens that fell out, we're there. We'll be there for you. So anyway, these are World Cup related injuries that might occur over the course of this tournament. So as of this recording, it's late June, and the U.S. has won their first two matches. By the time you hear this, we'll know the outcome of the third, and I'm excited. I've been really enjoying watching soccer. This is the only time, I'll be honest, I'm a fair weather soccer fan. I don't follow it religiously. I know a lot of the main players just from watching the World Cup matches. So I've been really enjoying Messi. I've been enjoying Erling Haaland, the Norwegian guy that looks like a freaking Viking. That guy's massive. He's like 6'3", 250 pounds. Like, honestly, he looks like an NFL linebacker. It's crazy. I've been enjoying him. Mbappe, phenomenal, unbelievable. So it's been a really fun World Cup so far. So eye injuries. We're going to start with the obvious one, which would be taking a soccer ball to the face at like 70 miles per hour. These shots are coming off the foot so hard. I can't believe this doesn't happen more often. Obviously, there's deflections all the time. I still have not seen, I don't remember seeing like a face full of ball. It's a really weird way of putting it, but I stand by it. Just a soccer ball directly to the face, directly to the eye, the orbit. What could happen there? I've seen this. I've seen kids come in with this. I've seen all kinds of youth sports injuries. Any kind of ball sport has this possibility. So if you get a shot from Erling Haaland, the Viking, directly to the face at 50 miles per hour, what can happen? All right. So one thing I'd be concerned about, because what we're doing, we look at the mechanism of injury. All right. So in this case, we're looking at blunt trauma, very high velocity blunt trauma. Worst case scenario is you have an open globe. There's two weak points to the eye. All right, the right behind the extra-ocular muscles, which is kind of on the equator of the eye about. So if you imagine, the front of the eye being the cornea, back of the eye being the optic nerve, about halfway back from the cornea is where you'll have the equator. So around there, underneath the extra-ocular muscles, you have the sclera, which is the wall of the eye, gets very thin. And it's there you might see an open globe injury occur. Another place is right at the edge of the cornea. That's also a very thin part of the sclera, what we call the limbus, which sounds like one of the Harry Potter broomstick names, the brand name brooms, Nimbus 2000, right? So those two spots is where you're looking for an open globe caused by blunt force trauma. If that doesn't happen, that's great. Obviously, you're wanting to do a dilated exam because you can get what's called a retinal dialysis, especially in young people. This tends to happen where you have the trauma from the compression that occurs from this blunt force can cause a little cleft in the. It's a form of a retinal detachment that occurs way out in the periphery of the retina. Fluid can track in, cause a detachment. So you can get a retinal detachment from this type of trauma. Obviously, looking for that. What's most likely going to happen? What are the most common injuries from something like this? Well, if the player was able to close their eye before getting hit by the ball, which usually is going to happen unless it's very unusual. You have enough reaction. You don't need much time, a fraction of a second to close your eye reflexively. And so you're unlikely to get like a corneal abrasion. We see corneal abrasions from ball strikes usually when it's a smaller ball, like a golf ball, a baseball, tennis ball, even a pickleball. Soccer balls are relatively large, and so I think you're less likely to hit it hard enough and fast enough to prevent any kind of reaction as far as closing the eye. And so what I'd be concerned about would be a hyphema. So hyphema is blood in the anterior chamber, the front of the eye. And basically what you're doing is you're compressing the eye so much that it causes a shearing force on some of the vessels that sit in the anterior chamber angle of the eye. That's where your drainage tube is, in case you're wondering. The trabecular meshwork. Drop that during a dinner party. Trabecular, how are you? Can I tell you about the trabecular meshwork? There's these bridging vessels that if you get hit with a soccer ball hard enough, it'll shear those vessels and cause blood to pool in the front of the eye. Anyway, do you have any summer plans? That kind of thing. So it's a serious injury because the eye pressure can be affected. That's when we get concerned about hyphema. Seen lots of hyphemas in my career from a variety of different things. It's the pressure. It's all about the eye pressure. You see blood in the front of the eye, you have to get an eye pressure. So any of you emergency docs listening, got to get a tono pin, however you want to do it, a Schiat's tonometer, even just kind of lightly pushing on the eye. Get a sense of, does it feel like hard concrete versus the other eye, which is nice and squishy. So, if the eye pressure is normal, then you can just let the patient needs to stop playing soccer. All right, gotta get pulled off the field. Sorry, buddy. You're done. You're done. You cannot play soccer with a hyphema because you can cause. First of all, the vision's going to be pretty poor because you're going to mix all the blood up. You need to be a couch potato with a hyphema. All right, you don't want to move around too much. You can do your normal daily activities. Certainly no sports, certainly no running, jostling, anything that's just really shakes you up quite a bit because you don't want to damage those vessels anymore because the second bleed is always worse than the first bleed. You want that to heal. You want those vessels to heal. And it takes about a week. Usually we tell people you need to be a couch potato until we see the blood completely go away. Once the blood's gone, then you're out of the danger zone. But if you have a secondary bleed or just a really bad hyphema that fills up the eye and causes the eye pressure to be sky high, then sometimes you have to do a surgery to clean out that blood. You pull it out, you suck it out, vacuum, irrigation, all the works, and resolve it that way. Also on a series of drops, we always put people on prednisolone because usually if there's blood in the eye, there's also inflammatory cells in the eye as well. That's going to cause light sensitivity. So that's what it would be like if you took a ball from Erling Haaland, the Viking, straight to the eye at like 50 miles per hour. I don't know how hard they kick it, but that ball is moving. The fact that they can kick a ball from outside the box, which is like 30 yards or something, and straight into the goal, and with the keeper being unable to react fast enough tells you just how quickly that ball is moving. I don't know how they kick it that hard. Must be because they're professionals. All right, next eye injury. And I'm not sure why this doesn't happen more often, is people smashing their faces on the goalposts. There's so much, like when the ball is right around in the 6-yard box area, like right in front of the goal, it's ping-ponging around. And there's people moving in and out of the goal, around the goal. I'm amazed that we don't see more players just turn and just smack their face straight into it to the side of the goal. Amazed that doesn't happen more frequently. But what would happen if it did? Well, Sue, as opposed to a ball, which is obviously a curved spherical structure, that's going to be more likely to evade the protection that your orbital rim offers. So you can feel it. You have the bones that encircle the eyeball. That's the house. That's the roof, the floor, and the walls of that your eye sits in. The orbital structure. Your eye sits in there because the orbital rim, those bones, provide protection. Now, they don't protect well against spherical structures because obviously it can go directly and hit directly on the eye. The sphere part of it, the shape of it allows it to penetrate further into the orbit and affect the eye. But a piece of board, something totally straight, is more likely to impact the orbital rim and cause other problems. Two in particular, from someone smashing their face on a goal that I would anticipate. One would be an orbital fracture. So the most common place for an orbital fracture is the orbital floor and the medial wall of the orbit. The bones are very thin there. And with an orbital floor fracture, what you're most concerned about is the possibility of entrapment of the extraocular muscle, which is a pants patient. All right. I hear about a possibility of extraocular muscle entrapment. I'm putting on my pants, coming in to see the patient. So that's the first thing I'm ruling out. All right. Obviously, you come in, a player from Argentina smashes their face on the goal. They're going to get a scan as soon as they get to the hospital to look for orbital fractures. Then you look and see, is the extraocular muscle, could it possibly be caught in that fracture line? If it looks like it might be, and you have the patient do ocular motility, look in all directions, and the patient's not able to look up with that eye, then you are very concerned about the possibility of extraocular muscle entrapment. You're calling up the ophthalmologist, say, put on your pants. You got to come in to see this patient. And then we do what's called forced duction testing to see if there's actually an entrapment there, which means I numb up the eye real good. I take a nice, sharp, toothed forceps, and I physically hold onto the eye and move it in all directions. And if it moves where it's supposed to move, then I'm not concerned. There's no entrapment. And we just let the eye heal, let the face heal, and then reassess the need for a repair of that fracture in 2 to 3 weeks. The other thing I'm concerned about with this type of injury would be eyelid lacerations. Let's take a break and we'll come back and I will tell you how I deal with eyelid lacerations. Hey, Kristen, remember how you love eyelid mites now?
Mm-hmm. Sure.
Yeah. Well, there's a lot of confusion out there. I want to clear something up.
Okay.
All right. People think they can get eyelid mites from dogs and cats.
Can they?
No. These particular Demodex mites are specific to humans.
Okay.
So spread from dogs and cats is not expected. That's a myth.
Can't get them from cuddling our poodle.
No. Demodex mites that cause blepharitis live on humans. Most adults already have them. They just usually don't cause problems. It's when they overgrow that they can lead to itchy, red, irritated eyelids, those little collarettes.
Mm-hmm, the crusties at the base of the eyelashes. Right. And the good news is there's a prescription eye drop available for Demodex blepharitis.
That is great news. To learn more about eyelid health and Demodex blepharitis, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. Okay, eyelid lacerations were actually one of my favorite things to deal with on call. Because I like suturing. I think it's relaxing, honestly, to sit there and just put in like 30, 40 sutures. I mean, maybe not for the patient, but usually they're in the operating room, an emergency setting. No, you're not putting someone to sleep for a traumatic laceration repair. And so actually that is not quite as fun as suturing in the operating room because as a 6'4" person, it's really ergonomically suturing in the emergency department can be a nightmare. depending on the patient's position and where they are and their status, and how it's not made to do that So it's worth it, by the way, to take the time to try to get yourself ergonomically comfortable, because after you spend like 45 minutes in a really awkward position, you will pull a muscle and be very sore and hurt yourself. And that's the last thing you want to do on call on 4th of July, is be in pain. So, but for eyelid lacerations, there's one big distinction with two distinctions with an eyelid laceration. Is it above the brow or below the brow? Well, if it's above the brow, then it's not an eyelid laceration. But ophthalmologists often get called with anything even close to the orbit. So if it's in the brow or above, that's way less concerning. And you can repair it just like you would any other facial laceration. All right. You can put deep sutures in if it's a deep laceration. You can just and then use your suture of choice. I often would use fast absorbing gut suture if you're more worried about scarring. If it's a very sensitive place, then you can use something that's a little bit less inflammatory, something like a Proline or nylon. But you do have to take those out. So there's lots of different options for suturing. If the laceration is below the brow, then you're getting into the eyelid. And one thing you don't want to do is put deep sutures in an eyelid. Do not put deep sutures in an eyelid, because there is an eyeball underneath there, folks. You don't want to do that. All right, so skin sutures only. You don't worry about it. It can't go the skin. It's not so deep. If it doesn't go through the eye and into the eyeball, which is another thing you do with an eyelid laceration. If there's a laceration in the eyelid, you got to check and make sure that whatever cut the eyelid did not also cut the eyeball. Very important. So you're putting in skin sutures. Again, fast absorbing gut. Just use your Proline, whatever your choice is there. But chances are, again, this is a goalpost, right? We're talking about. So you're probably going to miss a lot of the structure, the eyelid structures itself. Now, if the person's horizontal, then they could catch it, kind of horizontal. And for an eyelid laceration, if it's below the brow, the next thing you have to determine, other than is there an open globe or not, always check for that with any trauma, is does the laceration involve the eyelid margin? The eyelid margin is where the eyelid touches the eyeball. All right. If it affects the eyelid margin, that's a trickier thing to repair. Anything else, I would let an emergency department, they do tons of suturing. So emergency physicians, great, they suture all the time. So I'd be comfortable with them fixing anything below or above the brow unless it involves the eyelid margin, because it requires special technique of suturing to bring that margin together exactly right. Because if you don't bring it together right, then it'll scar unevenly and potentially result in misdirected eyelashes that start rubbing up against the eye, which can cause ulceration. So be very careful about eyelid margin lacerations. And unless you're like in a rural environment and all you have is Texaco Mike around the corner, and the decision is either fix it yourself or send the patient 2 hours by ambulance to a hospital, then I think it's reasonable to look up a YouTube video and try to do it yourself. But otherwise, and by the way, the farmers, they're not going to want to go 2 hours away. They'll just do it. You do it, or I'll do it myself in the mirror. I'd much rather you do it. The medical professional. So anyway, that's a distinguishing characteristic. Does the laceration involve the eyelid margin? Another distinguishing characteristic would be, does it involve the canalicular system? So any laceration of the eyelid closer to the nose, you have to be very concerned about canalicular, and that's even a more difficult laceration repair that I don't even feel comfortable doing. I'll do an eyelid margin laceration repair, but the canalicular system, which is where your tears drain, it's a series of tubes. And if you cut the tube, well, you got to put the tube back together, which includes putting a temporary tube in before the natural tube will heal over the artificial tube. So anyway, there's just a lot to it. You don't want to do that yourself. So that would be a bad goalpost right to the face, boom, injury. I got one more for you. And then maybe next week I can brainstorm some more. So another one would be let's see, I'll set the situation is. So you have the player who gets tackled and falls down, and I've noticed that the soccer players they have. I'm not saying it doesn't hurt when they get kicked, because they're always getting kicked. You're trying to hit the ball, you hit the shin, you hit the calf, you hit the ankle, the foot. That hurt. It hurts to get stepped on. The amount of anguish on their faces, like it's like it looks like someone in the worst pain imaginable. Now, I'm not saying they're not in pain. It's just, it's a lot. It's the grimace. Mike, they would get a perfect APGAR score with that grimace. It's just, it looks excruciating. And then they fall on the ground and roll around a little bit. So one possible injury would be that they for some reason decide not to grimace so strongly, and they leave their eyes open while they're rolling around on the ground, and the grass causes a corneal abrasion, and maybe also gets into the eyelid fornix. So that's the next injury, is flopping induced grass exposure, which can do one of two things. It can cause the corneal abrasion. I've seen lots of different types of plant matter cause corneal abrasion. But also, if they could get an allergy. A lot of people have allergies to different kind of grasses. Now, I assume a professional soccer player would know by the time that they're participating in the World Cup, whether or not they have a grass allergy. But you never know, especially an exposure directly to the mucous membrane of the eye. So if you get a couple blades of grass stuck in the fornix of the eye, and the fornix, if you pull the lower eyelid down, that glossy, wet-looking red stuff on the inside, that's your fornix. It's basically just that potential space underneath your eyelids, all right? And it's the reason why something like a piece of grass or an eyelash would not go all the way behind the eye. It'll eventually stop somewhere because you have a fornix. And that's like it's a little potential pocket, but it also prevents things from progressing back into your brain. So you don't have a brain that's just covered in eyelashes over the course of your life. And so, but maybe there's a little allergy there. So what would we do for allergy? Well, the first thing I do is recommend over-the-counter drops. There's a couple good ones, Patanol or Pataday. The same thing, just one's twice a day, one's once a day. And Zatador is another good one. Those are my go-to antihistamine drops. We actually don't have a great allergy drop that's over the counter. Oh, that's a prescription. We don't really need them because those two work just fine. For severe allergies, you can also do a short course of a topical steroid like prednisolone. There's other ones that have less into the eye penetration, like loteprednol or Lotemax. So there are lots of different options for more the acute phase of trying to calm down an allergic reaction, and then longer term as well. And then that abrasion, give them some eye drops. You can put a contact lens on the eye if you want, but not necessary. And the pain will dramatically improve within 24 to 48 hours. All right, there you go. 3 World Cup related injuries. If I come up with more, I'll because the World Cup goes for like a month and a half or something. So there's plenty of time for more World Cup related eye injuries. That's it for Knock Knock Eye. Thank you all for listening. I'm your host, Will Flannery, Dr. Glaucom Flecken. Thanks to my executive producers, Aaron Corney, Rob Goldman, and Shanti Burka. Editor and engineers, Jason Portiza. Our music is by Omer Ben-Zvi. Knock Knock Eye is a human content production. I'll see you next week.
Knock knock. Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.